for House Healthcare on the 15th of January. Before we get started with Devin Green from VAS, Leslie would like to introduce an intern that's going to be working directly under Leslie's supervision, but assisting the whole committee in helping us out with things. So if Leslie wants to introduce.
Yeah, Erin, right here, Erin Steinke. She's going to talk about herself, and then, but what I want to say is, so far I've asked her to do two things. Sorry, Pepper, from this morning. Jessica had mentioned the Green Mountain Care Board meeting about the AHEAD model. Unfortunately, it was canceled. Right. But I did ask Erin to watch that meeting for us and summarize, what happens to that meeting, so she could bring that back. It'll be written, so unless there's something that we want to have a dialogue, so that's fine. And you'll let me know that. The other thing I just asked her to do was to create a document of all the requests that we heard this morning, so that we could have it in one place from each organization in one document. So I think that might help us understand what's coming forward. So those are my requests so far. I'm going to ask that we put in requests through me, just so we don't overwhelm her. This is my first experience with this kind of model of having a committee intern. But we have Kristen, but now we have a little more staff. So let's enjoy that expansion of our staff.
Great.
So go ahead.
Erin, do you want to come up here?
In the hot seat?
So I'm Erin Steinke. I'm a UVM student, and yeah, I'll be here on Wednesdays, but I'll also be working remotely throughout the week. And yeah, I'm looking forward to helping you all out this session. Great.
We're really happy to have you.
I will say she's a political science
wondering.
major. Yeah, so that bringing her into the state house. Just maybe say a second about why you want to do this.
Oh, yes, of course. So yeah, I've always been passionate about local government specifically. In my opinion, I think it's easy for people to think that the federal government doesn't really work for them because it's hard to get things done. And I think what got me into local government specifically was Vermont, because it's one of the only states that really preserves direct democracy through town meeting. So I sat in on a town meeting 2 years ago for a class, and it was unlike anything I've ever seen because I'm from Long Island and that's a screaming. So that's what really brought me in here is I really enjoy witnessing how local government plays out in ways.
Great. Thank
So
you.
she really saved me because I wanted an article and I couldn't figure out how to get it. But she got it. So that kind of stuff.
Erin, would you mind closing our door for us?
So thank you for that. Your first event.
Come in and then we'll go out to you. Thank you. And we have Devin Green from VAS, and she can give the whole name. I'm just going to go with VAS.
Yes, thank you. Thank you for having me here today. My name is Devin Green. I am with government relations at the Vermont Association of Hospitals and Health Systems. So a little unwieldy. We usually go with VAS when we're talking about things. And I'm going to start off with just a high-level overview of the landscape and how this may impact all of our healthcare before moving on to what VAS and our hospitals do. It will go. Okay. So I think you all know this, but I think it's always worth stressing that Vermont's landscape is rural and aging. So according to the 2020 census, we're the most rural state in the nation. That is because unlike places like Montana, where a lot of their population is concentrated in the metropolitan areas, Vermont actually has a lot of their population spread out across the state. This is one of the things that makes Vermont great, but it also makes healthcare really difficult, and particularly when we talk about transportation and getting people to the right care at the right time. The other piece that I think is really important to point out is that we are aging. So this chart shows where we are in 2010 with our population and the age ranges. And you can see with that green line, the shift towards Vermonters aging. So we've had a significant increase in the 65 to 79 age group. We've also had a significant increase to those below 65 and below Medicare. And that has led to greater lengths of stay and more complicated health issues. So this slide shows what I was just saying in terms of the demographics. So we're seeing that patients are sicker. This portion on the left talks about the case mix index. That's the sort of acuity, how sick is the patient. What the federal government likes to try to do is map this out at like a 1, and we're now at a 1.54. I think the average is about 1.36, and that has steadily increased. Patients are also staying longer, so you can see that bear out as well. They're staying more days. Do you have a question?
Oh, I'm sorry, the sticker,
No, go ahead.
sorry. The sicker thing, what is that?
So the case mix index is a way to measure the acuity of the patient.
So the ratio or something of.
Yeah,
Never
I
mind.
could not actually get into like
Okay,
how
never
it is
mind,
all done. But it is a measurement that CMS does, and we are seeing it increase.
That's helpful that it's from CMS, so thank you.
Yeah.
Is there correlation between sicker, staying longer, and increased age of the population that's sicker and staying longer? Or are younger people getting sicker and?
Yeah, that's a good question. I would need to go back and look at that a little bit more, but I know we've been seeing news articles about people getting cancer at younger ages. So let me look into that. I think a lot of us, anecdotally, what I hear from our hospitals is, Vermont's done a great job in primary care for the last 20 years. We have the logger, who's my neighbor, who probably would have died of a heart attack at 50. And because he's changed his diet and he's exercised and he's gotten into primary care, he hasn't died of that heart attack and he's had interventions, but now he's 78 years old and has COPD and has much more acute needs and chronic needs. So he's gotten a lot of quality of life, but he's facing different problems now than you would have seen 20 years ago.
Thank you.
So I'm going to take just a moment to explain what VAS does and then get into our member hospitals. So VAS is a trade association. We represent all of the hospitals in Vermont. We do not represent the Vermont Psychiatric Care Hospital. That's the only one that we don't represent, but everyone else we do. And it's really a back and forth thing. So we are not only talking to leadership of the hospitals, but we're talking to the chief medical officers, the chief nursing officers, the IT directors, the human resources directors. We really try to get in at every aspect of the hospital and talk to those members as well so that we can understand the issues that they're facing. And our hospitals are throughout the state. We have 16 hospitals. They're all nonprofit. We have 8 critical access hospitals. Those are hospitals that are a special designation under Medicare, where Medicare has recognized that access is a problem in rural communities. And so they have provided a way for small hospitals, 25 beds or fewer, to exist in those rural communities so that they will have access, and they get paid at cost or just a little bit below cost from Medicare. We have one academic medical center that's also our tertiary care center. They take the sickest of the sick with UVMMC. We have 5 inpatient psychiatric care units throughout the state. We have 1 freestanding psychiatric inpatient with the Brattleboro Retreat, and we have 1 VA hospital.
Can you just describe what a tertiary care hospital is?
Tertiary care is just like the trauma, like the the really there are hospitals that can deal with strokes, and then there's the really bad cases, and that needs to go to a tertiary care hospital essentially. As a couple of our other providers have mentioned, hospitals are also highly regulated. We have a couple of layers. One is federal regulations. So all of our hospitals take Medicare, and there are a lot of requirements that come with Medicare called conditions of participation. There's also the IRS tax code. Since we're all nonprofit, there are requirements that we must meet there. We're overseen by the Green Mountain Care Board. They look at our budget. They look at certificate of need if we want to open up a new service or expand. They deal with the health resources allocation plan, which is to look at all the healthcare throughout the state. And they've worked on hospital sustainability with Act 167. Department of Health oversees hospitals in terms of licensure, our community health needs assessment, hospital report cards, and emergency management. And then our 5 hospitals with inpatient psychiatric units are overseen by the Department of Mental Health, which designates those inpatient units.
Robert, did you have a question?
Yeah, I have a quick one.
Yes.
Certificate of need.
Yes.
Can you tell me what the range is just quickly?
The jurisdictional
Buying a
thresholds?
new set of chairs or?
Yeah.
Are there any ridiculous things in that significant?
The truly ridiculous things like replacing boilers got taken away, or like replacing just carpets or something like that. Those were taken out, I think, in 2017. But I would say what concerns our members are the current jurisdictional thresholds, which are slated at either about 1.5 million or 3 million, depending on what the service or the function is. And basically, if a hospital sneezes, they're going to spend that much money. So a lot of things that they do falls under those jurisdictional thresholds, and they often have to go to certificate of need, go through that process to provide that service. One example is, and one thing we're looking to change with certificate of need legislation is state-funded initiatives. So Southwestern Vermont Medical Center, you all approved adolescent inpatient psych unit at that hospital, and that has been held up in the certificate of need process. And so one thing we are requesting in that legislation is that those state initiatives do not have to go through the certificate of need process, because the state has already decided through the legislature as a state that this is a needed service.
Thank you.
So I know that hospitals have been really under a microscope lately. And we are half of the healthcare spend in Vermont. So we're a significant amount of the healthcare spend in Vermont. And I know you all are very concerned, and constituents are concerned with affordability. And we're not going to shy away from that conversation. We want to be a part of that conversation, and we want to be a part of that change. We think talking about affordability is really important, and we know that there's work to be done on our end. We also just ask that there is work done on all the ends when it comes to affordability. It can't just be hospitals. As Jill Olson was pointed out, we're all so interconnected that if there is cuts in one area, in home health, in mental health, we see all of those in our hospitals. If hospitals are also cut, the safety net is going to sort of fall out from underneath us. And we also just think that we're not the only area that can participate in the affordability conversation. We think that there are lots of areas that are worth delving into. So this is all just to say that, you know, hospitals are really concerned with affordability. We have had difficulties with the COVID years, as you can see on this graph underneath here, especially in 2023, you'll see that high increase, but we really do try to keep our average annual increases at a reasonable rate and something that matches inflation. So we have an average annual increase at 4.4%. We're trying to get back there after the COVID blip, and we'll continue to do that work.
All right.
Such a huge issue, and like you say, from all aspects of our healthcare system, not just hospitals. What does VAS or what do hospitals see as like what are the mechanics to get everyone that needs to be at the table talking about how to address this?
Yeah, I think the mechanics of getting everyone at the table is, I think that's a real opportunity in the next phase of Act 167 and the Agency of Human Services feasibility study. So I think in terms, this is so nerdy, but I'm very excited at the prospect of, you know, really sitting down, digging into what's the cost benefit analysis of making these changes, what's the impact that it has on the community, and what are the opportunities that we see here. I think in terms of you all just helping hospitals and healthcare providers develop those relationships within their communities and supporting that, I think would also be helpful, because obviously we know that the cavalry is not coming. We need to work with the resources that we have. And I think there's a lot of important work that communities need to do in terms of sitting down and saying, hey, this is what we have. Where can we send this resource? How can we partner here? How can we share this doctor? And all of those sorts of things.
So I'm clear on this chart. Okay, so right now we have 2024, 4.1% increase. But that's building on a 10.5% increase, which is built on 5.2 and a 5.6. I mean, we're looking at 25% increase in 4 years. Which maybe I'm gonna look over to the healthcare advocate. Is approximately rate increases for insurance over the last 4 years, correct? Approvals
Sorry.
or close?
Missed your screen there.
Oh,
Mike Fisher, Healthcare.
I mean, you talked about affordability, which of course is a theme. I guess what I'm saying is, does Voz think this is sustainable?
And by this, you mean the 4.1%?
I guess what I'm saying is, you know, we blame it on the COVID impact years, but it's not as though we had the COVID impact years and then post-COVID, we went down to even out. We just keep going up and we're building on the high COVID impact years. So, you know, to see, oh, well, okay, we're down 4.1%. Well, yeah, but that 4.1% is built on this anomaly of those years.
Yeah. I mean, I would say that the anomaly of those years are still present in terms of during that time. So, you know, 60% of our expenses are workforce costs. And during that time, a lot of hospitals rightfully and necessarily, and probably long overdue, made increases to their workforce in terms of compensation. And you can't really go back from those increases. And then you also have inflation on top of it. So I would say that this is not out of the norm, but in terms of your sustainability piece, I think we have to look at the whole healthcare system and whether or not it's sustainable at this point, because as you heard from everyone else today, we're clearly very close to a breaking point.
Thank you.
One piece I did want to touch on was this other expense to hospitals, which is the hospital provider tax. So this just goes to show in terms of hospital contribution to Medicaid, the hospital provider tax ends up, we collect about 250 million from hospitals. With federal match, we get 450 million. And the cost of inpatient hospitals is at maybe 350 million. So there's about 95 million there that Vermont has extra from hospitals to put towards Medicaid.
You,
Just so I mean, I'm not sure if this was Leslie's question, but if I'm following your thread, that hospitals pay provider tax, which then, of course, is able to receive federal match. You receive it back in hopefully increased payments. And you're saying that you're paying in more in provider tax than what you feel you should be getting back with the federal match. Is it, Leslie, am I,
well, I'm not, yeah, I'm sort of following it.
and that's going somewhere else, that you're
Going somewhere else.
subsidizing,
Well, where is it? Is
say,
it?
the other organizations that we've spoken to in our system of care?
Yes, well, and I think the question is, we're not quite sure what we're subsidizing. There used to be like the Health Resource Allocation Fund, and we don't have this any longer. This just goes into the general fund. And so we would be curious to know where that funding is going towards and learn more about that.
I'm sorry.
Yeah, me
Leslie,
too.
I-
Because I was at a meeting and the question came up is where does the provider tax go?
Mhm.
And no one knew.
Mhm.
So that was a really curious kind of problem. And I think we need to go deeper. If we're going to take any action on it, I think I for one need to understand it better.
My understanding, provider tax goes to the general fund.
But I mean, I like
General
to,
fund dollars are used by Medicaid.
no, but it could
I think
go elsewhere, is what
federal
you're saying.
match.
It doesn't always go to Medicaid, doesn't necessarily go to
I don't
Medicaid.
know.
I think that's what they want to know.
Yeah, well,
Yeah.
that's what I'm saying. Me
Right.
too.
Me too.
Yeah, me too.
So in terms of affordability and access, we're really digging down into this. We've met with chief medical officers, chief nursing officers. What can hospitals do in this space? What can BOS do in this space? And we have a couple of proposals that do not need you necessarily, except for the sort of FAR proposals. But we want you to be aware of them and the work that we're doing in this space. So the first one in the now box does need you. Really, we would like to expand talent pipelines. I'll get into that into the next slide. They've been very successful. I think there are a lot of benefits both to providers and to community members with those talent pipelines. So we're advocating for that this year. VAS is also looking at a bed capacity tool to better coordinate for transferring patients to know where this will passively pull data and let you know where there are open beds at each hospital and not require hospitals to input data at a point in time, which usually ends up being pretty inaccurate pretty quickly. We would like to look into centralizing administrative functions like credentialing. Can we have one organization do credentialing for all hospitals, particularly our smaller hospitals, so that they don't have to spend administrative money doing that or administrative time? Really dig into measuring financial outcomes internally. Provider and patient stewardship initiative. I talked a lot with our clinicians about, we were really healthcare resources are not unlimited, right? And we had a really successful movement with antibiotics, where how do we not give patients unnecessary antibiotics? How do we give them the right services that they need without, them going to other physicians and asking for antibiotics and that thing? And what else can we do that with? What other services that patients sort of expect now and physicians feel obligated to provide because it's expected? How can we change that dynamic and really dig down deeper into making healthcare more of a limited resource and not totally, just think of conserving it a bit more. Not to say that we're denying care or denying access. We want to increase access. We just want people to get the right care and not unnecessary care. That's going to take help from you too. That's a culture shift. We need leaders talking about that with their communities. Otherwise, they might just go out of state, and then that's even less control over the costs. We want to look at interoperability for electronic medical records. We know it's too expensive to have one EMR in the state of Vermont. We're definitely not going to build that. If we buy it through Epic, that's going to be a ton of money that we don't have. But there are ways that our three biggest EMRs can talk to each other, and we need to work on that. So Boz will be working on that with our hospitals. So that's all right now. Quality maternal health care as well. There are quality initiatives, even if your hospital is not delivering a ton of babies, which a lot of our Vermont hospitals are not because we have the lowest birth rate in the nation. You can enhance that care with some quality programs. So that's all the work we're doing right now. And then we have a vision for the future too. The biggest thing long-term is housing. That's a double whammy for us in terms of our patients, certainly, and also our staff. So we'll be supporting all housing initiatives too.
Are you done with the slide?
Yeah.
Topper, did you have a question?
Yeah. I want to talk about interoperability.
Oh, boy.
Years ago, Vital was created for that specific purpose. And I'm just like, how much involvement now does Vital have in that process?
I wish my colleague Emma was here because she would be able to answer that a lot more cogently. I am gonna ask to come back on the Vital question because I know they're doing some really interesting initiatives and I want to be up to date. So I'll come back with that.
Same question?
No, I saw electronic medical records and it being under the category of now and knowing the crisis that we're in. I also have a deep appreciation for data and creating efficiencies and knowing the impact that has on cost and also access. But going back to cost, also one of the most expensive things that we can do in our system is investing in EHRs and interoperability. So when you were looking at cost benefit analysis, why did you put this in the front of the timeline?
Yeah, because when we sat down and talked with our IT directors and our chief medical officers, they mentioned how, this might be doable. It's probably not going to be perfect seamless interoperability, but we have a couple of, Epic and Cerner are our biggest EMRs in the state. And so given the fact that we only have a couple EMRs and they have recently developed ways for them to talk to each other. And what we need to do is put governance agreements in place and just operationalize it. I say just operationalize it, but sort of open up that portal between them. It's definitely worth, I'm not saying we are going to achieve it now, but I think that's where we start.
And our mental health providers are using 2 other EHRs, right?
Mhm.
Right. So this would just be for the hospitals.
It is a place to start for the hospitals.
Leslie?
Well, my question is back to the provider tax, so I don't know if you want to keep it to the end or do it now.
Let's keep it till the end.
Yeah.
Because we're getting short on time.
I know that, and yeah, it's a quick question with with a non-definite answer, so I just want to get it on the table. That's all. I want to get it on the table.
Legislative priorities, really quickly, workforce pipeline. It's been really helpful. You provided $2.5 million in funding in 2022. The programs that received that funding, there's a total of 160 students enrolled for 2024 in those programs. The programs that did not receive that funding have 16 students in total for 2024 enrolled in those programs. So that funding truly made a difference. And again, I think it's a win-win just in terms of people who don't have degrees, being the first in their family to get degrees and being put into a true career ladder. So any funding in that area would be deeply appreciated. And then certificate of need will be in that discussion for sure. And then let's maximize federal and pharma dollars. So that's protecting the 340B program, maintaining it at the status quo that you heard Mary Kate talk about earlier. Maximize DISH payments to hospital. Mike Fisher has talked about this a bit. We are leaving federal dollars on the table because we have up to 44 million we could be receiving from the feds. Right now we're at about 22 million. If we invested 10 million, we would get up to that $44 million. So that is another opportunity to bring federal dollars in. Okay,
Thank you.
thank you.
Oh, Leslie, did you want to get your question on the table?
Please,
And then maybe.
it was on there again. It says explore hospital provider tax revenue options.
Yeah.
And I'm just wondering where that happens, who does that? And, how do we start that? How does that process start or whatever?
That's a great question, and I'm not sure. It's
That's what
why
I
I'm
was
giving
hoping.
it to you, but
Yeah.
happy to work on it.
Yeah, I'd be really happy to be, let me know.
Great.
Next we have
Thank you.
Thank you.
Amy Johnson with Vermont Care Partners.
We'll get set up here.
All right. Hi. Everyone. For the record, Amy Johnson, Vermont Care Partners. I'm the Director of Government Affairs and Communications. I should probably wipe off my glasses so I can actually see.
You got new glasses this year.
I did. I mean, I have a lot of pairs, so you'll see all of them this session. All right, so I'm gonna do just kind of an overview. You heard a lot of the gloom and doom from everybody else. I want to say ditto to the gloom and doom. But I will touch on some of this. I will say that we have our CFO group working on a lot of financial information for this group. We'll come back during budget discussions to be able to talk more about some of those pieces. So I've kind of left that out of this conversation and really wanted to paint an overview for folks. So Vermont Care Partners is a membership organization. There are 16 agencies that are part of Vermont Care Partners. There's 18 organizations, designated agencies, and specialized service agencies written into state statute. We support 16 of them. And I think that it's really important for you to be able to see the map and see who the agencies are and what type. So for the conversation here, we have people that provide developmental services only. That's kind of governed by Dale, so that sits in House Human Services. So we won't talk about those folks. We have substance use providers and mental health providers. And so the mental health crew is kind of who we're talking about here. So that's most of the designated agencies, not all. We have one designated agency that does developmental services only. So it gets a little funky, but I try to make it as simple as possible for people to understand who are the organizations, what type are they, and what do they provide? So you understand kind of who you're supporting in this committee. As I said, we're a community-based system of care providing mental health services, substance use services, and services for individuals with intellectual and developmental disabilities. So when I talk about designated agencies have specific catchment areas. For example, Howard Center, which a lot of people know, their catchment area is Chittenden County. And so when we talk about specialized service agencies, they can operate across the state in more geographic areas. One of the things that I wanted to note was designated agencies. Our services are voluntary. I think that's really important for people to know that we can want to support somebody, but they have to engage in services with us. Designated agencies have a no reject policy, whereas specialized service agencies can choose for a variety of reasons to not serve somebody, but designated agencies don't have that choice. And I don't have a slide on payer mix because I've been working with the CFOs to get that, but our payer mix is a majority Medicaid, and that's why we'll come to you around rate increases, because those Medicaid payments are what funds our organizations and keeps us afloat. And we know, as you've heard from the group today, those rates don't match with what the cost of care is. And so our ability to keep the lights on and stay afloat is very challenged. And as we speak, there are conversations about, where we're going and if there are programs that we have to shutter, which is really unfortunate because we do serve some of the highest acuity and most vulnerable Vermonters in the state. And so when those programs are shuttered, they either go to the ED, where it's higher cost of care, it drives health insurance rates up, and kind of we've seen how that's played out in our state over the past X number of years. So our services this is really simplified. We do so much, but our services, we provide children and youth mental health care, adult mental health care, emergency services. So I'll talk about our crisis continuum, intellectual and developmental disability services, substance use, and then community outreach and education. Here you'll see, I think it's covered for me, but we provided over 3 million unique services in fiscal year 24. I did bring our impact report, so everybody will get a fun copy of that. But the other piece that I wanted to point out was our pie chart, this little mini pie chart in the corner here. When people think about our services, a lot of times they think about in an office, a clinician and a client sitting on a couch one-on-one. That is much less of what we do than community-based care. We're embedded in other practitioners' offices, we're in homes, we're in schools. We are meeting people wherever they need us. And I think that's really important for people to know that we are providing services mostly in homes and communities, residential facilities, crisis beds as well. So it's not just kind of a one-on-one on the couch doing counseling. So you'll see here, this is a more comprehensive view of what we do. So I am going to talk a lot about our crisis care continuum if I have time. I'm going to try and pace it out. We'll see. But we know that we're always going to need the crisis end of the continuum because that's just the nature of how the world works. We won't need as much of an investment in that if we start to invest in upstream services. So the less we invest in upstream services, the more we're going to need those crisis-based services. And I want to be really clear around this. Our crisis services are fantastic, and our partners at DMH have done a wonderful job to help to develop this wonderful continuum. If somebody accesses those, it's really important to be able to plug them back into home and community-based care. If that system has been eroded, there is nothing to plug them into, and so they will continue to hit that crisis piece, which drives costs. And I will bring back my iceberg slide. Back by popular iceberg.
I saw it.
So you can see here, we do a lot of promotion and prevention work. We support around housing. If there's a question around housing, a lot of it is how do we keep people housed? So providing those supportive services so that people are stable and can maintain their housing. We aren't housing stock providers, but we do work with local developers to provide housing on site. Washington County is a really great example, has a lot of housing supports and housing stock, namely for the IDD population. Employment services, food assistance, you'll see a lot of social drivers of health in this kind of promotion and prevention space. So we do a lot of that upstream work in the community. And again, that the limited investment erodes that part of the system of care, which is really concerning. So we also have our early intervention. We want to act early. We're in schools, we're identifying issues, we're working with children and youth, we're working with their families to help them to kind of like mitigate that ripple effect of mental health barriers that are happening for kids. We want to maintain their academic environment. We want to support the family, create healthy home environments, and kind of limit the risk and impact of not intervening early. We have treatment. You'll see crisis, residential. We work with really high acuity folks. We have in our provider agreement that we have with the Department of Mental Health, we have designated populations that we serve, one of them being our CRT population, which is community rehabilitation treatment services. I think I have that right. And that is our adults with serious mental illness. And so that is a designated population that we serve. That's a really important population. And then we have our recovery-based services. So it's really vast what we do. Each organization has their designated population through the provider agreement that we are required to serve. However, organizations build out programming onto their region based on what is needed. And so I also want to put in here, sometimes people think we're siloed. I didn't say this in my intro, but I worked for the designated agencies for 9 years, 2 years at Howard, 7 years at NCSS. And I can say that we are very integrated into the community. We have boards that govern each agency. They're folks that are on the board are from the local communities. We have our local standing committees. That's a requirement of the organizations. Those standing committees are individuals with lived experience or families who have children or adults that they're caring for that have lived experience. Our staff obviously live in community, and we partner really well with our community providers, whether it's hospitals, home health, whether we're working directly with them peripherally or we're embedded in some of those centers. I know up at NCSS, we have staff embedded in pediatrics that kind of build the bridge back to our care. So I already mentioned this really briefly. So we have designated services that we provide in our provider agreement, children, youth, and family services, our emergency services, and then developmental service waiver services. And then I already talked about our community rehabilitation treatment, which I did get that acronym right, which is exciting. Are we good at what we do? Let's ask the folks that we serve. So this is from our impact report 2024 client satisfaction outcomes. So you can see here, folks saying I received the services that were needed. The services made a difference. Staff treated us with respect. And so those are really high percentages. Those surveys go out annually across all of the folks that we serve. And so just, trying to show, are people better off? It's really important how much, how well, and is anybody better off? So we want to highlight that. So we get asked a lot about vacancy data, so decided to put a slide in around this. One of the things that I will say around vacancy data is it is really challenging to, if we're asking for an increase and we're getting a percentage of that, and if years in a row we're only getting a percentage of our ask, that gap in funding is really big. So it is really hard to keep people. It's really hard to retain and recruit folks. And so, yes, our turnover data has improved to some extent, but without aggressive investment, that's really not going to shift in the way that we want to. Our turnover rates have improved. Has our encounter data improved? That's a really complicated question. I'm asking the questions myself, but I know these are questions that folks have that have been directed at us recently. We're seeing high acuity folks. When we look at the encounter data, it's not just, I've seen this person once a week, maybe I've seen them once a week, but for 4 hours. So it's really how we look at that data. We are seeing a lot of high acuity folks, and we still have a lot of vacancies. So you can see we're a 6,000 person network and we have 5,200 people currently staffed. So we are going to see some improvement in hours and encounter data, but it's still a challenge. And I will say that it is very difficult to recruit people when somebody looks and says, this is what the pay is for these positions, and there isn't a guarantee for an increase. It would be really hard for me to take a position or stay in a position where I couldn't guarantee that my wage was going to go up to be able to meet my basic needs. And furthermore, I think it's a value on those systems and those services. If somebody might not even choose to go into that field because they can see, well, it doesn't pay very well, and it isn't regularly invested in. So there are other things that impact our vacancy rates. It's not about what are the DAs and SSAs doing around recruitment and retention. That's a part of it, but we also know that we have regions in the state that are childcare deserts that have limited slots. So it's hard for people to move to those areas and take jobs at our organizations if they can't find places to have their children go. There's food deserts, transportation, housing stock is a huge one. I know Devin mentioned this for her folks. It's the clients that we serve, and it's also staff. So there's a variety of factors that impact vacancy beyond what we aren't able to do.
We're running out of time. I just wanted to let you know, we're running out of time, and I see you have a lot.
I have so many slides. I have 1,000 slides.
You want to sum a slide, give a slide of summation, perhaps?
Slide of summation.
I think we've gotten a pretty good idea of what you do. It's very complicated and requires many slides.
I know.
I want to make sure you get to the iceberg.
Yeah, I will say that, the biggest thing for me, the 101 is for people to really understand what we do and where we do it and how we do it. And it would be great to be able to highlight some of the, amazing work that we do. This is kind of what people see when they think about the DAs and SSAs, or the high end, where we see emergency department visits, crises, news stories, law enforcement, but there's all this stuff that's happening underneath the surface that's really supportive of our state and creating a healthy and well, that's impacting global health of Vermont and impacts cost savings. So the issue is, if we keep eroding the home and community-based system of care and we're focused just on the crisis piece, we're going to flip this, the iceberg. We're gonna flip this. We're gonna build out that top end, that expensive kind of heavy part, and have less resources for that really important under the surface work. That is really critical. And to me, we're at a tipping point, and it's not surprising because of how things have been invested in. And we want to say that we are so appreciative to the legislature because our increases have really come from the work that all of you have done. And that has helped to keep us relatively afloat, or at least like continue to provide many of our services. But we are a safety net. We are serving the most vulnerable. And I think a lot can be done if we have that crisis available, but that we're investing in where we're plugging people back into, or where we're supporting people before they even hit that system. A million more things to say, but I'll stop there.
Well, I know we'll have you in.
Yeah.
Many more
I'll be
times.
here every day. I mean, not if you want me sitting here every day, I will, but I'll be in the room every day.
Thanks, Amy.
Thanks.
Thanks for coming in today for the first time. And just before we close out, we have Helen Laban, which I will confess, I thought it was BAN all these years.
It's pronounced that way. No one ever gets it right. So good that you envisioned it that way.
Okay, so it's Laban.
Yes, it's Laban.
Oh, okay.
You're right.
I was right. Just the you threw me there. Thanks for coming in.
All right.
Helen.
Thank you. I'm Helen Laban. I'm Executive Director of the Vermont Healthcare Association. It's been a long morning and it is almost time for lunch. So here's some good news. Most of our asks go in front of House Human Services. So this is mostly just here's who I am, here's who I represent. You can talk to me if you need more details for your work. So I do not have a long slide presentation and we can make this brief. So the Vermont Healthcare Association represents skilled nursing facilities, residential care homes, and assisted living residences. So what we're talking about there is all residential, all provide long-term care support. Some also provide short-term rehabilitation services. Primarily Medicaid funded. So this is a big discussion for state budget, but again, over at House Human Services, not necessarily here. On the other hand, everyone has already gone through the gloom and doom, I have heard. So we're going to see a lot of the same issues around workforce, around covering costs of services, around changing demographics that you've heard others speak to. A big concern for you all here and that you'll probably hear from my colleagues is around access in my members. So especially when we talk about skilled nursing facilities, that is a last option placement. So the folks who need to go to skilled nursing or a nursing home don't have any other options clinically. That's where they need to be to receive the services they require. So when you hear, for example, about hospitals having barriers to capacity because they cannot discharge into a skilled nursing facility, that's what we're going to be worrying about. In Vermont, so a rule of thumb, if you're going to look at the trends of what you need for capacity just in terms of beds, unlike other states, Vermont did a bunch of rebalancing about 10 years ago that you see other states doing now. So what you heard about the investment in preventive services, investment in community-based placements, that has happened in Vermont. And in terms of actual physical beds, we really don't have any further down to go. At the same time, when you look at increasing demand, the general rule of thumb is if your demographics over the age of 75 is going up, then your need is going up because that's when high risk really starts to set in. The primary constraint on our capacity right now is workforce. And that's across the board. And Vermont is a real outlier nationally on that. We are an extreme outlier in our lack of nursing staff, especially in our LNA and LPN level nursing staff. Those folks where we need a lot of people there 24 hours a day to provide direct care to the residents. We also have lack of access to physicians and specialty services. Those are provided by medical groups outside of the skilled nursing facilities. We don't directly employ physicians. We rely on hospitals, private medical groups, FQHCs, the surrounding community to provide those services. Our members cannot accept someone for admission if they cannot guarantee that they will provide all the services outlined in the plan of care through the end of the person's residency in their facility. So unlike, say, an emergency room where the incentives are set up to take anyone who needs emergency services, we're the opposite. We need to guarantee that we can provide those services, including specialized services, through the full term of that person being a resident. And so you'll see a lot of statistics around facilities that have beds open, but they can't take the admission because they don't have access to the necessary physician services. I was just talking to a member yesterday who, since the start of the year, has denied over 60 referrals because of lack of primary care access. That's almost unheard of. Usually what we hear about is specialized services like substance use disorder, clinical psychiatry. Now we're hearing it's the primary care services that are denying that many admissions over a couple of weeks. So that's the crisis that you will most likely be hearing about that affects my members. Certainly also happy to talk about Medicaid, talk about healthcare reform, talk about the payment systems. Usually that's over in House Human Services. I see that it is noon 01, and I know that you've been here for a very long time. So I just also want to note, I focused there on the skilled nursing facilities because those have the most direct interface with other provider types that you'll be talking with. Certainly, same goes for assisted living residential care homes. We'll be looking for access to physicians, access to community services. Usually that's a lower level of acuity. So the dynamics are a little bit different there. But similar pressures that you'll be hearing from folks like Bi-State, folks like primary care providers in that context. So that's my 5-minute summary.
Thank you. First of all, thank you for coming in and introducing yourself, because like you said, we don't interact around skilled nursing, long-term care in this committee. It's in human services, but it affects every other player that we do deal with. So appreciate you coming in and introducing yourself.
And always happy to take questions, to come in to speak about a subject, provide any information you need to understand that context.
Great. Thank you.
Helen.
Thank you.
I know I have promised this, I think, 3 times, but the first thing, and we are back here right at 1 o'clock, please be on time. First thing, we are electing a clerk of the committee. Okay. So, thank you. Thanks everyone for coming in today.
See my text.